I'm Jo Stanford, and I head up the Healthcare Project and Change Association. And the event today is delivered jointly between ourselves and the Federation for Informatics Professionals. So we will have people from both sides of the community here today and looking at how we can work more collaboratively on improving EPR implementation. We've got some fantastic speakers for you today. So we've got Mandy Burns from Manchester Foundation Trust, and also IRIM, and who's going to tell you a little bit more about that. We've got Jooli Atkins and James Kane for NHS England, and the lost my words, Frontline Digitisation. It's a bit of a mouthful, but come to talk to you about what support is available for EPR implementations. So thank you for those starting to introduce yourselves in the chat. That's great. Anybody who's just come in, if you can introduce yourselves in the chat as well, great opportunity to network and share. We've got quite a bit to get through in this session, so I'm going to crack on. We have a Q&A open, so please do ask your questions in the chat or in the Q&A. We will be answering those at the end of the session. We also have a Menti for you just to find out where people are from and what they're working on. So we'll put a link in the chat to that. If you aren't subscribed to HPCA, please do. It's free for everybody to be a subscriber of it. We work really collaboratively with other associations, including FEDIP, to work more collaboratively and to look at where we intersect as professions. We've got regional networks in each of the regions in the UK, and we are here to support the project and change profession to develop organisations to mature their capability and for everybody to build core skills in project and change management. So if I can just introduce Sarah Scriven from the Federation for Informatics Professionals to tell you a little bit about them, and then we'll just do a little bit more before we get into today's topic. Sarah.
Thanks, Jo. Lovely to see everyone. Loads of people on the call today, so that's really great to see people from across loads of different organisations. I can see in the chat. It's one of the reasons why I was really keen to collaborate with Jo on this to bring us all together, because there's quite a few people who may not be aware of FEDIP. I'll just do a quick intro to us before we move on to the speakers. So we're FEDIP, Federation for Informatics Professionals and Health and Care. So we're the only UK public register dedicated to recognising professional registration for health informatics professionals. And we do this in collaboration with our 6 professional bodies, which underpins that registration and the standards across the workforce. So there's basically a clear, consistent expectation for knowledge, skills and practice across health and care informatics. And it helps gives us a little bit of parity esteem with our other registered professional colleagues in finance and in clinical. So we've got our professional registration there. So very quickly, just for those who aren't so aware of maybe of our professional bodies, they've cropped up on the screen. So there's AFA, who support the data analysts, BCS, who support digital IT professionals, CHIME, which is the College of Healthcare Information Management Executives, and this is why we have the acronyms, otherwise we'd be here all day trying to say all the names. And they support the senior digital leaders, your CIOs, your CNIOs, FEDIP, who represent the Library Information Association, IRIM, who I'll let Mandy talk about a little bit more because she is representing IRIM here today for the clinical coders and record managers, and finally SOCATIM, who represent digital leaders in local government and public services, the social care aspects of it. And the reason why I rattle off all of those is to say that it encompasses a great deal of professions. And one of the reasons why I'm very keen that we're here representing FEDIP with HPCA today is because in areas of work such as EPRs, the obvious one, we really do need to bring everyone together and to collaboratively work on these. So I'm really keen to have these joint webinars. The focus of this series is on organisational preparedness for digital transformation. addressing that analog to digital agenda point, and asking the question, actually, are we truly ready for digital? And EPR implementation is one of those key areas where success is really dependent on working across all of the professions to implement that. So on that point, I will hand over to Mandy to introduce herself.
Thanks, Sarah. So I'm Mandy Burns. I work in the NHS in Manchester Foundation Trust, which is quite a large organisation. We went live with our EPR in September 22, so I'm going to talk a bit about that. I also am Chief Exec of IREM, as Sarah mentioned. So IREM covers health records, clinical coding, data quality, information governance, all of those kind of backroom admin clinical support areas. I've worked in the health service for over 35 years, again, predominantly in that area. So that's kind of my background. I'm a director with FEDIP as well, so I'm IREM's representative for FEDIP. And I also am the UK National Director for FEMA, which is the international version of IREM's around the world. So lots of clinical coding, health records, data quality staff around the world have representation internationally. So I'll hand back over to Joe.
Thank you. That's great, Mandy. Great to have you with us today. So I'd like to introduce Jooli Atkins from NHS England. And let me just get... And also Julie's colleague, James Kane, who's also representing NHS England today. Do you just want to do a little bit of an intro for yourselves?
Yeah, thank you. Thanks, Joe. So hi all. I'm nowhere near as exciting as Mandy. I can't believe how many organisations you're involved with. So my name's Jooli Atkins. I'm the change management lead for part of NHS England known as digital partnering. So we're responsible for making sure that our national products are adopted across the NHS. So we work externally with our NHS colleagues rather than within NHS England. And one of the ways that we're supporting organisations at the moment is through our EPR support offer in change management, which is where I'm going to introduce James Kane because he's part of the team delivering that.
Hi everyone, yeah, James Kane, Implementation Business Change Manager. So yeah, I'm working on the same programme as Jooli, and yeah, last couple of years I've worked with a lot of organisations on the EPR implementations and helping them on the sort of change management side. So picked up a lot of experience and lessons learned, which I'm going to share some of that with you.
That's great. Thank you both for joining us today and sharing all of your knowledge and experience with us. So last quick question for those that are attending today. What stage is your organisation at on its EPR journey? So there's some options here for you to select. And it goes from nothing confirmed, you haven't necessarily gone down that journey yet. You might be in the development stages, partner selected. Moving on from that in design and development, that it's being progressed, and then mid-implementation, you're getting it out there. Go live and that it's up and running. Post-implementation embedding, that you're building on that, or you've actually gone quite far down that road and you're in the maturity and improvement level around this as well. And for those that are at that end of the scale, your knowledge and skill and experience will be really helpful for those that are at earlier stages of the journey. So if you have any key points or hints or tips for those that are still have that journey to go, do drop them in the chat and put your best ideas for what would be of value for others to learn in the chat. It's always great to share that knowledge and experience. We also have a survey at the end of this to capture some learning. I think Sarah's already mentioned this, but also we want to pull that evidence together to bring some knowledge and experience together around this. So more of that at the end. But just while you're doing that, we'll swap over. And Mandy, if you are good to go, this gives us a great insight into where people are at on their journey. So if you can share your journey with everybody here and the lessons you've learned from that, that would be fantastic. Let me stop sharing so you can. That's great.
Everyone see that?
Fantastic. Yes. Great.
Perfect.
Thank you.
Okay, thank you. So we went live in September 2022. So this is some of what we did before, what we did during, and what we're doing afterwards. I won't go through who I am, we've already talked about that, but just to put in perspective, MFT, we account for around 10% of activity within NHS England. So we're obviously located in the northwest of England. We're the largest single trust. We have 10 hospitals, 2 local care organisations, and a whole variety of specialist services that run from one of our hospitals. We formed together over several years, as you can imagine, to become a trust of this side. So we inherited at the point of go live around 1,000 systems that we had to look at and monitor prior to that. It was a 2-year programme of work we implemented. So we made the decision to go with Epic as our EPR, and you'll see I refer to either Epic or Hive. The worker bee is the Manchester symbol, so we called our EPR Hive just to fit in with that. So we had a 2-year programme of work ahead of go live. One of the first things that we did for my areas was we centralised things like data quality code and health records under what was then informatics, but is now digital services. And we also had a huge piece of work trying to align our patient numbers, because as you can imagine, with 1,000 systems going across our 10 different hospitals, patients might have attended multiple hospitals and they'll all have a different hospital number. So ahead of the go live, we needed to try and align some of that, because we also had different hospitals using the same PAS system, but different instances. We might have had the same numbers in use for multiple patients as well. So it was a really significant piece of work that we had to do. So we did 2 separate programs of work under that called SPID, Single Patient Identifier. One for the Wythenshawe, Trafford, Wrightingham and Altrincham hospitals, or WATWA, and one for North Manchester that joined us a bit later on prior to go live. Just a bit of background. Clinical coding historically was set up in specialties and site hospitals, so the group of coders only looked after what was say general medicine in Wythenshawe, and another team would look after orthopedics at MRI, and that's how they worked. So they were all brought under one umbrella under myself, but still worked in that specialty and site hospital location, because obviously we were physical case note driven at that stage, so we couldn't move, or it wasn't practical to move the physical case notes around purely for coding. Clinical documentations weren't the greatest. Some people's writing, I'll hand up myself included, is awful. So we really needed to try and put a system in that made clinical coding much better as well. How did we manage missing information? Well, we'd usually run around, try and ring lots of different departments, chase ward clerks, secretaries, not always get it. So we would never fully code because we couldn't. Some of our sites use things called encoder software that helps, but not all of them did. So we had a really vast difference across our coding background. For health records, we predominantly had physical health records. We used different tracking systems. We did sometimes send case notes across to different sites to support our patient's journey, but not always. We were trying to really establish what were the physical records being used for prior to go live, and what would they be used for after go live, because some of our clinicians did some digital work. So not everything was in the case notes, but we couldn't necessarily identify what was there, what wasn't. We also had COVID, so we didn't necessarily provide physical notes for every attendance during COVID. And if we could cope without them then, why would we suddenly put them back in or keep them going once we went live as well? As you can imagine as well, everybody called something different. So we had, dividers set up in each of the hospitals that bore no relation to the other hospitals in our organisation. People file things differently. So we really had a problem trying to identify what was in use. And we also had some records that had been scanned. So, for example, our Trafford Hospital and our North Manchester Hospital had all their physical case notes scanned prior to coming under the centralised team. So a really mixed media. And obviously I had a really large number of staff who managed moving physical case notes and what we're going to do with them after we went live. Data quality priorities changed both, from what they used to do on a day-to-day basis to in the run-up to go live. It was a real different concept around what would they be doing, how would they support go live. They had a huge role to play. We were asked to identify clinical pathways and support that. So if you're an orthopaedic patient, what are all the different stages you would go through as part of that pathway? Because that's how our new EPR would be set up. So the data quality team had to really look into what were all the different steps and who was involved in each element of the patient journey, obviously with clinical support, but it was a way of trying to map that journey so we could mirror it onto our new EPR. We also had, obviously, our data quality team needed to become experts in the system. They were experts in lots of different systems prior to go live, but we needed them all to become experts in the new system immediately. So they couldn't take the years of experience they had to become experts really quickly. So how are we going to do that as we moved over? We agreed some deliverables. So one of the things that we did was identify what needed to happen to make our go live work. Because
Sorry,
we
Matt.
had, okay. Because obviously we were pulling all our information in from our different systems, we tried to, we ended up migrating around 4 million patient records into the new system. That was, again, as part of that SPID project I talked about earlier. We had to create some new patient numbering, and that was around 1.5 million numbers that we had to create, and that also then meant we had to renumber the physical case notes to match that as well. The clinical coding team, we needed to ensure that we could manage our long-term patients over the go live period. So anybody who was in a bed before go live, during go live, and would be there after go live, how could we safely manage their coding journey as well? Because we're not allowed to stop them and start them if it's one continuous episode of care. And we also, obviously, we rely on our coding so much for our income that we were worried about any drop in coding and therefore a drop in income. So we really had to, again, concentrate on how we skill the coding team up and be ready to deliver from day one. Health records, slightly different. We were looking at how do we manage our staff. So we had around 200 staff. And obviously what we were trying to do was give them enough skills both to cope with our new way of working post go live, but also ensure they had the skills if we needed to look at moving them elsewhere. Sure most of you know case notes don't always contain everything, so we had lots of loose documentation all across our trust. So we did a loose filing repatriation where we got 1,000 documents in within 3 months prior to go live and had to file them away into our case notes. We also had some case note amnesty days because tracking on multiple systems isn't always up to speed. So we got around 65,000 case notes returned for filing within a 2-week period, which was quite a lot more than normal. And we also worked with our clinical staff around what we were going to deliver from day one, as in, the legacy case notes being provided at the point of care. So we had 192 locations or services that we supported before go live. That went down to 130 at go live, and we now look after 2, which are quite unique. We also, from the data quality team, one of the things that was identified very late on in the programme, so we were going live in September and we were told in April we could only have a duplicate rate of 3% ahead across the trust, and we were then at 17. So we had a massive programme of work to get that under. And we also had to look at all our open registrations, which across all the 10 hospitals were around 5 to 6 million. And again, we're all those legitimate and genuine. So we had a few challenges, as you can probably imagine, we had COVID in the middle of our prep. And we had to set up the Nightingale Hospital in Manchester to serve the Northwest. In May 22, so a few months ahead of our go live, we had a massive electrical outage at one of our sites, North Manchester. That meant we lost all other than emergency lighting and power for 17 days. So we couldn't even get in some of the departments at one stage because the doors were electronic. We couldn't print, we couldn't buy a cup of coffee because all the tills, everything went down. So it was significant. And then a week after go live, we also had an unplanned downtime of 24 hours there as well. So quite challenging time. Go live, we had an issue with upload of legacy scanned documents. Unfortunately, for some reason, the script was corrupted at the point of go live, so all our testing worked, but somebody wrote the code for the script going in rather than just copy it, and inverted 2 letters, which meant we had a significant problem, so we had to change that as well. Post go live, we have a large volume of physical paperwork that is still floats around the hospital. So a lot of this is from other organisations coming into us, and we needed to ensure our process for managing that was in place, considering most people are saying, oh, you'll be completely paper free at the point to go live. We're not even now 2.5 years on. We've got still a few ongoing we had a few challenges immediately post go live. So some of the issues with our interfaces, so things like ICE wasn't picking up the same patients in our new EPR as it had previously, so was creating duplicate patients. So I think on day one we had something like 50,000 duplicate patients created. So we had to, really jump on board and get that resolved quite quickly. And then reporting was obviously a significant concern, because we were reporting previously from all our 80 systems. Now we were reporting from one, so our figures looked very different than what we've previously been discussing with Department of Health, NHS, etc. And we also had a big drop in coding at the point of go live. This chart, just very quickly, you can see our go live there in September, where we have a real big drop. However, post go live is a completely different picture. Our average prior to go live was a clinical coding depth of just under 6, so around 5.7, 5.8. Now our average coding depth is around 9. So we've gone from being in the blue line, continuous line is our position in national ratings. So we went from being in the bottom 10 now to being in the top 10, and our clinical coding staff believe that is because obviously all the data is A, legible because it's typed, and B, because it's there, it's all in one place. We don't have to wait for case notes, we don't have to follow paperwork around, it's all in one place. So a really good positive outcome for us. Our experience on the day, we had around 3,000 super users, 230 external floor walkers and 200 staff from Epic supporting our go live. It was the biggest go live in Europe and the second worldwide. We had our staff fully transacting on the day. We did have a bit of a awful day, to be honest, though, because that's the day Queen Elizabeth died, so morale kind of did a big nosedive. So we went from being really super hyped and super positive to quite low, as you can imagine. Post go live, we've decommissioned a huge volume of our legacy systems. We're fully on board with optimizing, so we're really exploiting and exploring different ways to use our system. All our national reporting, as you'd imagine, 2.5 years on, is fully live, and we have significant confidence in its accuracy, whereas before, obviously, as I say, we were pulling together multiple strands from lots of different systems. SOPs are all in place. We had no adverse events reported during the go live period or post that has been related to anything digital related to EPR. I have put at the bottom, we're not a full EPR yet due to some EDMS being worked on. So that is we've still got our legacy scan physical case notes. And obviously, some of you might know, we had two main national inquiries, the independent inquiry in child sexual abuse, as well as the infected blood inquiries that prohibited destruction of any records for 9 years, near enough. So we have 9 years worth of physical paperwork to get rid of, as well as making a decision, which we're in the process of making with a business case, to digitise those remaining physical notes that relate to patients who are still active with us or who have a long retention. Our trust activity since go live, so this is up to September last year, so for our first 2 years, we have 453,000 patients or their representatives using our patient portal, which is MyMFT. We've had 33,000 babies delivered successfully, 1 million emergency admissions. I won't go through them all, but you can see we're fully utilising our system, and there's some great stories there in that little web page that is next to it around what we're doing, who's involved, how we're moving forward. Some of the key lessons that we learned during the experience, one of the big ones for me is staff are resilient and they will respond if you create the right ethos with them. So basically include them, don't hide things from them. You know, my records team, for example, where we knew we were going to be reducing staff, we did a lot of that through natural wastage. So I've gone down from having over 200 whole-time equivalents. I now employ about 130 whole-time equivalents. We've got them doing lots of different jobs, supporting the EPR as well as supporting the physical case notes still. So we've really tried to expand their knowledge to make them fit for the future as well. We really had a mantra of clinically led, operationally delivered and digitally enabled. We've changed our structure, so we have a lot more chief clinical officers or CXIOs in the organisation. They obviously do a mix between supporting the digital team as well as their clinical role, and they've really helped and brought us on and shaped us for the future. It's still very much a clinical led system. And don't be afraid to descope. So what do you need for safe and efficient go live? And if it doesn't fit with that, you can always park it and come back to it when you need to. The other big one for us was cleansing your staff records before you go live, because otherwise people either don't get the training they need or they get training they don't need, and there's a gap in what you are able to support and deliver. So for example, nobody other than the health records team got any case note tracking because that was how it was set up. Whereas if we'd have looked at what people did in their day job, we'd have changed that and made sure everybody would get case note tracking, because we still were moving case notes around, certainly in the first 6 months or so. So that's kind of a very brief and quick overview, and I've just got a couple of slides on IREM. So who we are, we've been around since the NHS was formed in 1946. We actually started in Manchester, same as the NHS again, and we were originally AMRO, or the Association of Medical Records Officers, and that converted over several years into IREM. We are predominantly an examination board and a membership body, so we support the National Clinical Coding Qualification. That's our exam we deliver, and we also have a suite of health information management qualifications that run alongside, and they vary from things like CTC, Certificate of Technical Competence, very similar to an MVQ, right up to a diploma level as well. All our board are volunteers. We all do this voluntary in our spare time. And we have a whole structure of who's should be involved. I won't go through all this in detail, just aware of time, but obviously there's some benefits there around being a membership body, who's involved, how it would benefit you as an individual. You need to be a member of a professional body to be on the FEDIP register. There's certainly a good benefit, and there's some organisational benefits as well, which obviously include that professional representative. and there are just some further information there if you are interested. I know we're going to circulate the slide pack for everybody if they want it, but links to our site as well as the FEDIP website are there. And that is the presentation done.
Fantastic. Thank you so much, Mandy. That was brilliant. A real brilliant insight into the journey that you took and the challenges and issues with it. We've got a few questions from people that have dropped them in the chat, and we'll capture those now if that's okay.
Yeah.
These are just in the order that I captured them. So, how many clinical stroke functional requirements did you have? And did you develop demo scripts with patient stories?
Oh, so the first one, I don't know if I could answer that straight off. I'd probably need to go and have a conversation with some of our clinical colleagues, because I wasn't necessarily involved in all of that side. We did have our patient stories though, and we tracked them through as part of our pathway development. So we involved patients as part of obviously the EPR implementation. We engaged with them, and we kind of plotted their journey is both pre and post to see actually does the EPR help them. So we did work in that way with our patients as well.
That's great. I'll just ask you another one now, and then we'll take the rest of them at the end. So we've got to make sure we've got time for Julie and James to talk about their bit. So how did you manage to complete all of the as is and to be process maps with so many external issues across a multi-site trust?
So with a lot of difficulty is probably the short answer. The longer answer is we did have obviously a really robust program team wrapping around all this that was made up of both digital services, operational teams, and our clinical support. And we probably, Post-it noted everything to death. So we really had really good mapping sessions, day long at times, and we spent a huge time. So I know I said it was a 2-year journey, and it was. We did have COVID in the middle of it, and we did use some of that COVID downtime where we reduced activity to exploit. Let's get all some of this mapping done while we've got capacity. So that benefited us in a way because we were at reduced clinical activity, so it did help us, but it was a very much a fully rounded team. So it had to be clinical, it had to be the operational teams as well as the digital services supporting it. But we did have, as I say, some really good program wrap around to keep us on track and keep us managed.
Brilliant, thank you. We do have some more questions, but we'll come back to those at the end if we may. And I've been capturing those that have been putting them in the chat. So can I just thank you for those insights? And what we'll do is we'll hand you over to Julie Atkins and James Kane now to talk a little bit about what's available to support you on your journey. You are on your journey to your destination. So thank you, James. Let's just
thanks.
Thank you, Julie.
So James is going to take us through the support offer for Frontline Digitisation. So we're funded to support Frontline Digitisation trusts in NHS England, but that's not the only thing we do as well. So James will also introduce us to our change management network that can help everyone.
Thanks, Julie. Okay, yeah, so I've already introduced myself. So yeah, let's start off with what our support offer entails, who we are, what we do, and how we do it. So it's a change management service, and it's been developed to support and guide teams and organisations to navigate and prepare people for change. So what we do, we do offer a tailored interactive learning package designed to provide an organisation with those fundamentals for change management and those techniques. Also, a key part of our offer is every trust we work with, they have a dedicated trust liaison. So me personally, I have a number of organisations in the Midlands that I'm helping them on their change management journey, supporting on them along the way. And they're really appreciating that person who can add that, subject matter expertise in this area. And then how we do it. So yeah, we do it through our facilitated learning offering that comes out of the change readiness review, which I'll talk about shortly. One of the key things we help organisations do is develop a change network. We also work with them in terms of helping them develop key change collateral, such as change management strategies, plans, engagement strategies, etc. You see below there's some key tools that we help organisations work with them in terms of developing things like when they're doing their engagement and comms and the stakeholder analysis. We've got some key tools that actually they can input that information into that tool, and it helps them see what they need to do for the change. So that's just an overview, but I'm going to now go into a bit more detail about our offer and how we've overcome some of the challenges. So one of the first things we do with an organisation is we conduct a change readiness review. So one of the challenges around change management, when we think about the technical side, it's a little bit easier to follow a certain methodology, but in terms of change management, it's like, where do I start for this EPR? What do I need to do? What's the extent of work involved in terms of change management? And the only way you're going to really know that is to have a starting point, have a baseline. So by doing a change readiness review, it allows the organisation to see what's the gap between where they currently are and where they're trying to get to in the future with working new ways of working with that EPR. So we go through a number of statements and we facilitate that discussion with the organisation, and it's things like, do they have exec sponsorship? Do they have a vision? Do they have that sort of clinical sponsorship? Is there any resistance, maybe from past changes and things like that? So all those factors are scored, and it will give an organisation that overall change readiness score, which will indicate how ready they are currently. So we don't expect the score to be always that high if they're a couple of years away, but it gives them that score, and it's a baseline, and it can then actually think, well, how do I increase that score? And that's where we come in to support. We offer some recommendations on, for example, how to increase the score, how to help them with things like the change vision and develop things like that. One of the other challenges that organisations have is sometimes within an organisation, you sometimes get a strong, powerful voice who says, yeah, the organisation's ready. I think everybody really wants this system, not really hearing many complaints. But then when you get, the view of the clinicians or nurses, someone from that area, they say, well, actually, the clinicians don't really get this or don't understand the benefits. And then it starts to bring to light to everyone, actually, there is more work to do and we aren't as ready as we thought. So the great benefit of this readiness review is it's got that representation from ops, clinicians, nursing, all different areas of the organisation coming on to this readiness review. So you get a more rounded view of what's going on. And also those people like the CNIO, for example, they're acting as the sponsor for the area, so they can own some of these actions. And it's good for that area to have that representation, that sponsor sort of linked in with us, that leadership team owning this. So the readiness review is a starting point. And then what follows on that is it will reveal the extent of the work in order for that organisation to be ready. What do they need to do? So, for example, if it's one of the scores was they don't really have a change vision, what our team can do is come on site and work with that organisation on a change vision workshop where we have templates that we can work with the organisation to start thinking about what the vision is going to look like and start developing that. Now, one of the challenges with training around change management is sometimes it can be a bit generic. It's great to go on those sort of courses, but our facilitated learning is NHS focused. It really does include examples of things that the trusts have gone through. The activities and examples used are NHS and EPR focused. So we do, one of the feedback we've had from attendees is that the facilitated learning is relevant to them. Another challenge that sometimes people have is you go on your training and then actually you don't do nothing about it because you can't really see what the next steps are. But with our facilitated learning, actually people are starting to develop that vision, or starting to think about their change network, starting to think about who's going to be part of that change network. So they're almost starting to create that within our workshops, and then they can actually go away almost immediately and start the next steps. So that's one of the things our support offers really helped in terms of overcoming those challenges. So at the top, you'll see that's the sort of core recommended learning. They're normally longer sessions, come for a whole day or half a day. And then in the middle, it's additional learning, things like process mapping, 4 modes of change. They're more virtual sessions, an hour and a half. And again, organisations have really appreciated things like process mapping. We've gone in, and sometimes organisations just need a bit of refresher on how to do process mapping. Also, there's a challenge sometimes with capacity with organisations in terms of they don't almost have the staff, or they don't have the time to develop the training material. So we can go in and train their trainers to help them deliver some of their training that they're going to have to do to the people that are going to be impacted by this change. At the bottom, you'll see a number of tools that are part of our key tools that are part of our toolkit. So this is where organisations can access our toolkit and get access to some of the key tools. And the great thing about these tools on our toolkit is there's templates for you to pick up, but also examples, again, NHS focused ones, so they can see how this would look like in practice. So I just wanted to bring you up, focus on some of our feedback we get. So all of our facilitated learning, we do ask attendees to give some feedback so we can improve on what we deliver. I'm not going to go through all of this, but I just want to focus on one key area here that should come up highlighted in a second. Yeah. So in terms of, we ask attendees about risk awareness of delivery challenges and changes. And from the feedback we've had from all our learning, facilitated learning, is 92% have felt that this is increased, with 53% greatly increased. So it's showing you people are coming to our sessions and they're actually have much more awareness of things maybe they didn't realise about how this is going to impact people, what needs to be done. And as well as that awareness, just as important is, okay, here's some of the challenges, but what can you do about it? So we give them techniques, models, things that they can take away to address some of those challenges. Next bit of data I wanted to show you was, we talked about the change readiness review, and what it is gives you that organisation, that baseline score for their readiness. And then we work with the organisation. The outputs of that will lead to a number of change interventions, like the facilitated learning, or support in terms of developing maybe their change management strategy or engagement and comm strategy. So you should see, as those interventions happen, the scores should go up. And on average, individual scores have increased by 22 points from the baseline to the latest. So it's showing you what we do with organisation is actually having an impact. Where they started off with, at the start, they're now improving their scores, and essentially they're becoming more ready for the change. Now, the FD support offer, we're working with on EPR. That's some of what we do, but we also have this change management network, which is for the wider NHS, for any sort of commission or change that's out there. And it's on the NHS Futures workspace. And we've got 2,354 members, and it's growing all the time. And we've talked about already, one of the key components is the toolkit and its tools. There's 70 plus tools and techniques in there. And one of the challenges organisations have found in terms of change management before was, you go on the internet, there's all these tools and everything out there, but there's not everything's in one place. So what we've done is bring that all together in one place. So it's really easy to find those tools and the ones that you need for your change. Also, one of the really exciting things is, as the community, the membership's grown, we've got a really good discussion forum. So when there wasn't that many people, there wasn't that much chatter, but now the community is growing. You know, every day, every week, I've been seeing people post something like, so if you think about it from an organisation point of view, it's like, I wonder what other people are doing in terms of what are they putting into their engagement and comm strategy, how are they dealing with resistance, so they can actually start a discussion. And what we're finding is other trusts are adding to the discussion. So yeah, I did this or I did that, and can we have a chat and talk through how you did your change management strategy? So it's really allowing this to grow that community of practice. And also, now we've got all this membership, we're running masterclasses on different change management themes. So we've run one on resistance recently. This month, we've got one coming up on change readiness. So that's another one that'd be really good to join. So these masterclasses just help enhance people's knowledge and skills around change management. Now, you should see in the link in the chat a link to this network. And yeah, please sign up if you haven't already, and you'll get access to all this wonderful stuff that's on there. Now, one of the challenges that organisations have also found is that change management, is there a framework? Where do I start? If I do this, what happens next? What's that lead to? So it's not just like a bunch of tools. We've actually tried to fit them into a framework. So people can actually see, where do I start? You can see there, phase 1, do your vision, your case for change. What's that lead to? And you can follow this through. And our toolkit's based on this framework, these 5 phases you see on here. So you can actually drill into any of these phases or any of those outputs that are in green, and it tells you the activities you need to do, for example, the change vision, and it links to all those tools, those templates, techniques that you can use to achieve that. So yeah, this is something that organizations have found really beneficial, something that they can actually think, yeah, where do I start? What's next? It gives people that roadmap really in terms of change management. Okay, so who's it for? So one of the good things that we've developed here is quite simple. You can almost rate yourself on your change capability, where you are, and that change network, the toolkit, it's for everyone really. And it doesn't matter if you're a novice or you've got a bit more experience. You can come in, you can learn things, and you can start to say, okay, 6 months later, a year later, have I improved in terms of my change capability? So by coming onto the network, by joining the discussion forums, the masterclasses, using some of those tools, practice, put them into practice, you can start to see that your change capability will increase over time. Right, that's it from me. So hopefully you found that interesting. Yeah, join the change network. The link's in there in the chat. Any questions?
Fantastic. Thank you so much, James. That's really great insight. And we've given links in the chat. We've got lots of hands clapping alongside to support that. It's a really fantastic resource to support organisations and individuals to come together to help each other on this journey, because we know how challenging it is. So we've got quite a few questions in the Q&A. Sarah, are you happy to ask some questions that are in there? Those that have been sort of upvoted most, because we've got quite a few. We're not going to get through them all, I don't think. What we will do is, if you're happy, we'll send them out to the speakers today. And if you don't mind, Mandy and Jooli and James, perhaps providing some answers, and we'll send those out along with the links to the recording and the slides. So, Sarah, did you want to pick out a couple of questions that you think are most pertinent?
Yes, I'm going on a rough basis of upvotes and also thumb emoji, so it's not massively scientific, but so the first one I think that's got a lot of votes is there any research on organisational, individual or team satisfaction within EPR products that provides a ranking system in relation to productivity? Barbara asks. I think that's probably open to everyone.
I can talk about EPR usability, if that's which is not quite the same thing. So I think the answer to the question is no, not that I'm aware of. But NHS England's just facilitating an EPR usability survey that will give some indication as to usability, but that should help us to extrapolate that into some elements of productivity. But I'm not aware of exactly what's in that.
Thank you.
Yeah, I'm not aware of any either. Not something I've come across at all, unfortunately.
I wonder if that's something between collaboratively we might want to to put in place. As I say, I know about the usability surveys, but I don't think we've got something between us. That's something to look into, I think, for definite. I think for Mandy, following the go live, did your organisation experience any challenges with documentation quality, particularly regarding note bloat through the duplicated content, copied clinical entries, and what impact did that have on the productivity? Also, what strategies would you suggest to mitigate this? From Jonathan.
So we had both. So we had lots of copies of information, but we also had obviously clinicians who weren't used to using a keyboard, so that's quite evidenced by our drop-in coding too. So how we got over the first was basically every time we picked it up, and it was usually the coders or the next clinician online, because they're no to contemporaneous, so the next clinician in could see that things had either been duplicated or that sort of thing, or if it come to the coders, and we would go back to that individual. We've got, as part of the EPR, we've got a chat function, so users can ping the clinician, and that's what we use. So we ping them straight away to say, please can you go back and edit your note, and we pushed it back to them all the time. So they learned quickly that unless they wanted to get lots of tasks in their inbox, in their in chat, they needed to go and do things correctly the first time. So it took us probably a couple of weeks, but then we don't none of the team are reporting that now to me, so it's obviously working.
Great. And then another question, I think probably all of you might want to come in on this, but for Mandy, I think originally, did you do any digital skills analysis? Like, how did you baseline the requirements for the skills that you needed?
So across the board at MFT, we ran some upskilling sessions for everybody. So a lot of drop-in sessions. We put up like kind of cafe style. You could drop along, familiarize yourself with keyboards, with using Windows if you weren't compatible to that. More locally, particularly with my health records team, I had people who didn't even have, kind of modern mobile phones. Some really basic Nokias were in use. So we did a huge amount of work with them, and our learning and development team supported us with that. We offered apprenticeships. We had very limited take up on that because the team were not interested, but we did some really local specific training where they could work as a group, because they felt more supported with their colleagues around them, people in the same boat as them. And then those who kind of identified an aptitude or an interest, we've really supported them in developing those skills further. So we've seen really a big shift. So a lot of my natural wastage in the team has gone from internal promotion into other areas and other skills. So a lot of them have moved over to things like clinical coding, data quality, validation, things like that, as well as into other areas across the organisation. So we did a mix of open sessions for everybody as well as targeted training.
Yeah, thanks, Mandy. I don't know, Julia, James, if you wanted to come in on anything you'd seen in terms of how people are dealing with skills gaps or anything like that in your work.
Yeah, but pretty much as Mandy's just described it, but I think one of the main challenges is actually getting that baseline, because that's where the change network really comes in. It comes into its own because the members of the change network really know the individuals on the ground. So Mandy talked about, getting your data, your staff data cleansed.
Yeah.
We all know how difficult ESR is. So that in itself is a starting point for baselining, but that just tells you sort of who's where. We then need to go into detail, and personally I've got a bit of a challenge with this idea of digital literacy, because I have a thing about digital illiteracy. I think it's much kinder to think about it as digital fluency. So I think some of us, like when we're learning a language, I can just about get by in some languages, others I can be fluent in, and I think that's the same with digital. Most of us have a level of digital literacy. It's just then how fluent we become over time, and I think it's just it just feels nicer than saying you're digitally illiterate. It's not a very kind way of approaching it. So
thanks, Julie. Yeah, I definitely agree with that. That's less threatening. Definitely. Fab. Another one for Mandy. How did the trust go about relaying communication surrounding new training material to specialty groups to reduce front end errors, i.e. the length of stays or patient demographics?
So we did a really big mixed media communications campaign. So everything was obviously on our intranet. We had posters, we had kind of Teams meetings, we had walkarounds as well. So a lot of this was done through our clinical champions. So although we've obviously got our CXIOs and digital matrons and so on, a lot of our, nurses, therapists, as well as obviously all our other clinical professions, all identified leads within that, and they led a lot of the specialty changes. So back to where I was saying before, it was clinically led. It really was. So all those changes in processes and practice were delivered in normal specialty meetings. We might have had some digital representative there, but it was very much those lead clinicians that have been lead clinicians for a huge amount of time, really, making that change happen, making those specialties, changes, processes, everything happen. So I think that's probably really a big takeaway for me. It has to be led by your leaders in each of the areas, not just your trust board, similar to what James and Jooli were saying earlier, but it has to be, it's not just around getting your board on, engaged with the programme. It's those local leaders that you really have to get on board with as well.
So for me, there's this thing that we call a change network. You can call it whatever you want, but there are two roles in that, and one of them is what we call the change agent, which are the people, as Mandy said, they're the people who know that job inside out, and they're the ones that you really want to be defining your future processes, not some IT technician that doesn't know what the job is. But then you've also got change champions, and they're the positive chatter. They're the people that keep the messages alive. And for me, in a trust, there's always a porter that knows everyone and knows everything. And you get them on board as a change champion, you'll hear all the rumours and they'll get all the messages exactly where you want them to be. Porters, housekeeping, you wouldn't naturally think of them as being involved in an EPR, but get them on board and your engagement will soar.
I back that 100%. So my transit team in health records, because they visited every ward area, every clinic area, every secretary, know everybody.
Yeah.
I don't, they do, and they were fabulous. So 100% Jooli.
And you'll get all the gossip back as well. So you'll get all the rumours that you can then start quashing before they become a big challenge.
Thanks both. So set up an industry of gossip around the hospital.
It will happen anyway. It's much better if the programme knows about it.
And Maddie, kind of a question that's probably your team more than you maybe, but how did you finalise on which tools and technologies, etc., be used for your organisation?
So from an EPR perspective, obviously it was a huge trust decision and went through normal procurement process. And obviously, that happened. The business case was a long time in coming. And if the decision was made in May 20, then this was a 5 or 6 year journey to that point, but it was through normal full NHS procurement processes with lots of people engaged in the reviews, the shortlisting, it was a whole kind of trust decision in a way, because of the amount of engagement and involvement it would need to have. Sorry, I don't know whether that answers, but it's it's normal NHS procurement process. Yeah, I don't know if Jooli, you can add any more to that. If you
just get your change agents involved as early as possible. So again, it's like, we hear so often from trusts that say, well, we haven't decided on our supplier yet, so we don't want to start thinking about change. No, it's not about the system. Get your change agents involved in helping you to decide which supplier's going to do the best for the organisation.
Maybe we can do a session with HCSA, the procurement profession, around what's the best way of approaching the procurement, because obviously it's a massive commitment for every organisation, and getting that right is going to set you on the right journey, isn't it? just mindful of the time. We've only got a couple of minutes to spare, and some folks are having to drop off now. Please be aware we do have 2 more sessions in this particular series. I've put the links in the chat. Do sign up to them. There's a really great insights from really experienced people, and also great to get your input as well. So do sign up for those. We have a survey, and this is around informing some research and a white paper. Please do complete that, and our particular feedback for this session, because it's always really valuable to find out what works and what doesn't work and what we can do better. And I just want to say a big thank you to Mandy Burns, to James Kane, and for Jooli Atkins for sharing their knowledge and experience with us today. And Sarah, did you want to say anything more from FEDIP about the session and the research?
Just very quickly, I'm conscious we'll all drop off in a minute and go get some lunch. But in terms of the survey, I know we're all surveyed out. So, you know, if you have the time, we'd be very grateful if you could contribute to it. I would like it to inform, as Joe said, a white paper around organisational preparedness. So the other 2 webinars that we have in the series, the links are in the chat, will also inform that paper to give a more kind of system-wide look at all the kind of areas we've spoken about today, whether it's looking for the skills gaps, whether it's identifying technology, what we need to procure, all within the digital data space. So if you do have time to contribute to that, it will inform that paper, and hopefully we'll have a louder voice as a collective profession to say, this has been our experience actually, and this is what we think other people need to know. This is what other organisations can learn from, but this is also what we need to consider for the future. So very much appreciate anyone's time, anyone who wants to get involved in that, and anyone who wants to help on the white paper itself, please feel free to get in touch if you'd like to work with it on us through HPCA or FEDIP or any of the professional bodies. And thank you all for being with us today. I really appreciate you taking the time.
Thank you, that's fantastic. And just finally, the link to the 3rd session, we'll put that link in the chat, so it is a separate link from the one that has been in there twice. So do sign up for them. It's been fantastic having you all with us today. Hope you find it really interesting and useful, and look forward to seeing you at the next ones. Thank you everybody for your input, it's been brilliant.